You are at the UHC at WD event. It's not the last time you're going to hear acronyms in this conversation. I can promise you that. But it is an important session. For those of you joining us online, right outside the door of our little conference hall here is the most beautiful scene of majestic mountains and the Vancouver Bay and seaplanes landing. So the folks who are in this room are in here because they care a lot about promoting quality girls in global health, and that's what we're here to talk about today. We are missing a key component, and that's my co-host, Lawrence Evans, with USP. Very unfortunately, he missed his flight, which is, I guess, apropos for the supply chain element of the conversation we are going to be having today. I'm feeling that pain too. I lost my luggage on the flight, so if you see me wearing this same outfit every day, it is my uniform for Women Deliver. Let's see what happens on that front. But it is an important segue, maybe, in today around quality medication, around the supply chain, and around really how do we get to universal health coverage. And there's really no way to get there. This is kind of the theme we'll hear from session to session during Women Deliver. There's no way to get there without considering equality. And I just finished writing a book, by the way. I will mention that a few times today, perhaps. It's called The Business of Changing the World. And it is really all about how the aid industry is being disrupted, how things are shifting. One of the key disruptions that I think I'm preaching to the choir about here, but it's important that we emphasize and re-emphasize, that when we're talking about all the advancements that have been made in the world, all the tremendous technological progress, there are still 10% of people in the world living in extreme poverty. That's 800 million people. And if you go to the countries where many of you go, where the challenges are very extreme, where you see high prevalences of poverty, this is not simply a question of resources. We can't just write a check to solve the problems of poverty. These are issues of injustice, of discrimination, of human rights. And that's why a conference like this, talking about the topic of global health, is so critical. There are technical issues at hand, sure. There are implementation questions, sure. But we need that advocacy lens as well. There's no way we're going to get there without all sides working together. And that's really what this discussion is about today. It's about how do we advance health of women and girls and the whole UAE agenda, thinking both as advocates and implementers. And we've got a fantastic team who are working on issues on the front line to have that conversation with us today. So I'm really delighted to kick us off this morning. If you want, for those of you following us online, the hashtag is WD2019. In fact, we have, and we're very honored to have, the chair of Women Deliver, opening remarks, Kristen Heddle. And this is a very busy time, so thank you for making time for this session today, Kristen. You are one of the people who helped found the UN Women organization. Women Agency spent a long career at the United Nations, now chairing this important organization here at Women Deliver. So thank you, and we'd love to hear your welcoming remarks.
Good morning, everyone, both near and far. So glad to know that we have people following us also outside of this beautiful conference venue. So I will not go into the technical details that the experts will discuss later. I want to talk more from a broader perspective from Women Deliver's point of view. And so on behalf of Women Deliver, thank you to Devex and USP for hosting this important session. And thanks to all of you for being here. I'm kind of pinching my arm that after so many months and years of preparations, we're finally here for Women Deliver 2019. And at Women Deliver, what we are advocates. We're advocates for gender equality and the health and rights of all girls and women. And while we are much more than a conference, every 3 years we convene the largest gathering of its kind to loudly promote the world's need for gender equality. Why? Because, and this is not news to any of you in this room, a gender equal world is healthier, wealthier, more productive, and more peaceful. And a gender equal world sees girls and women not as a special interest group, not as a minority, but actually half or the majority of the population, the norm. Why aren't girls and women the norm if we need one, for example, in medical research? The evidence shows that when the world invests in girls and women, there's a ripple effect that goes way beyond the individual. It benefits families, communities, and entire countries. And 2019 is the year of universal health coverage, the year when the global community must step up to ensure that all people have access to quality, affordable healthcare services. Because healthcare is a human right, it's not a privilege. Yet, each year, more than 3 billion people do not receive the health services they need. 800 million people face financial challenges while accessing healthcare, and nearly 100 million are impoverished by the cost of healthcare. Momentum is building for September's United Nations high-level meeting on universal health coverage, where governments will renew and strengthen commitments to achieve this lofty goal by 2030. When talking about universal coverage, it's easy maybe to conflate universality with uniformity. But we know different population groups have different health needs. We know that equity measures are needed for marginalized groups to ensure that all people can access the health services they need. Therefore, to truly achieve universal health coverage, and with it, its health, economic, and social benefits, we need strengthened health systems that reflect how girls and women seek and experience healthcare every step of the way. That includes, but it's certainly not limited to, their sexual and reproductive health and rights. Applying a gender lens to health is not an option, it's a necessity. Women face distinct health issues from men, which are often under-resourced and under-prioritized. In many communities around the world, women are not the final decision makers, even in matters of their own health. This inequality has a devastating effect on the health of women and girls. Gender inequality and unequal gender norms influence access to health services. For example, the imbalance of power between men and women is maybe the single most important cause of the higher rates of HIV and other sexually transmitted infections in women. So while the focus on universal health coverage in 2019 is commendable, it will be fruitless if discussions do not properly consider the unique health needs of girls and women and the interrelated aspects of gender equality and human rights, including the human right of girls and women to make decisions over their own bodies and fertility. Governments have a responsibility to ensure effective systems are in place, to provide a continuum of care for girls and women throughout their lives, that ensure access to a complete range of quality maternal, sexual, and reproductive health services and other services, including modern contraception and access to safe legal abortion as part of an essential package of services. In today's political climate, without an intentional, relentless commitment to gender equality, even well-meaning plans to advance universal health coverage can leave girls and women behind. Universal health coverage policy and decision-making must be transparent and inclusive. We must make room at the table for diverse stakeholders, including adolescents, women's organizations, marginalized groups, and professional associations, and make sure that their input and experiences are reflected in policymaking and implementation processes. At all levels, advocates like you in the room here and health professionals can play a powerful role to ensure that SRHR, there was an acronym, I think you know it, sexual and reproductive health and rights, gender equality and human rights are not shortchanged for political expediency. Importantly, girls and women should be involved in the design, implementation, evaluation, and accountability of policies, programs, and services. This year, Women Deliver is examining gender equality in the context of power. What is our individual power? What are the opportunities and barriers of structural power? What is the power of movements to bring change? And I hope that all of you here will continue to ask yourself throughout this conference and beyond, how will I use my power to create a more gender equal world? Thank you again for coming. Enjoy yourselves, but be nice. Soon will be 9,000 people here. I can't wait to see what comes out of this event and out of this conference and what we can accomplish together. Healthy girls and women are the cornerstone of healthy societies. Provide girls and women access to health throughout their lives, and they will deliver a healthier and wealthier world. Thank you so much, and have fun at Women Deliver 2019.
Thank you so much, Kristen. That was a fantastic way to kick us off. And congratulations to you on the start of Women Deliver 2019. It's hard to believe it's actually here. It's beginning. You inspired me just to tell two very quick examples or stories that I'm guessing most people have not heard. And one is about the co-host of the evening tonight, USP. Most people haven't heard of USP, even in the United States where it's based. It's the United States Pharmacopoeia is the full name. It's another acronym that gets thrown around occasionally. But we all assume, in my home country of the US, that when we go to the pharmacy and the doctor gives us a prescription, we buy a medication, that we're getting the medicine we were prescribed, that it will be of high quality, that there's a system somewhere in the background we don't even think about that it must be working. And that really is USP. The challenge is that does not exist everywhere in the world. And there are many places in the world where when you go to that pharmacy, you don't know exactly what you're going to get. And maybe you're getting a low quality medication or something that's been falsified. Maybe prescriptions that are being given are actually contributing to antimicrobial resistance. Maybe there's a larger systemic problem and we don't see what's in the background sometimes. We don't talk about it. And so that's the reason Devex and USP wanted to put on this event today, was to talk about what goes on in the background and how do we promote quality medicine, something that USP is a leader in, because these are the sorts of issues that sometimes get left out of broader conversations about UHC. So the second example, I think, is the kind of thing that gets left out occasionally. I want to tell you a little story about a woman named Jaha Dukure. Has anybody heard of Jaha here? Very, very few. One, okay. I was at a conference like this where I got to meet her. Eventually, she spoke at Devex World, our biggest conference. And Jaha is an advocate, a youth advocate for FGM. So she's from the country of Gambia, and she herself went through the practice of FGM, female genital cutting, when she was just a baby. And when she was 15, she was married off to someone in New York. She had to come to the United States. She was able to kind of escape from that marriage and went to New York City public schools, knocked on the door without any parental permission, somehow talked herself into being admitted as a high school student in New York, and eventually made her way down to Atlanta and eventually started her own little nonprofit. A little small nonprofit like there are millions of around the world working on human rights, on women's rights. She went back to her home country. She borrowed her uncle's car, and she drove around following the new president of the country at every campaign event. And she was there at the back of every room with her hand up, asking a question about FGM, until finally, about a year later, he agreed to meet with her, and he changed his mind, and they outlawed the practice in the Gambia. Now, there is a long way to go there and in many other countries, but I give you these two examples because I think they're the kinds of things we don't talk about enough that we want to get into today. They're the things in the background, the things that are happening at that grassroots level, at that micro level, real champions and heroes pushing us on advocacy, and then key technical and implementation questions that are also happening in the background. We want to get into that today. So we're going to begin with a little fireside chat. Christopher McLennan is with us. He's an assistant minister assistant deputy minister for Global Affairs Canada. He probably has the busiest schedule of this week because all 9,000 people want to meet with Global Affairs Canada, and so many of these issues are really pertinent to the work the Canadian government does. We want to talk a little bit with him about this work. And to have that conversation, Kelly Rogers is with us. She's an associate editor at Devex who leads our coverage. All the journalism you see on gender issues, she's the leader behind that. She's covered refugee situations in Bangladesh, at Cox's Bazar, across East Africa and the Mekong region, and now she's here in Vancouver with us. So I want to hand the stage to the two of you. Kelly?
Thanks so much for the intro, Raj, and good morning. What better way, I think, to start the day than with a nice, cozy fireside chat about women's health? I think both at the national and the global political level, there's a need, in order to meet SDG 3 in particular, there's a need to really promote well-being for all. And so we're here at Women Deliver, so why not dive in by talking about why governments should apply a gender lens when they're thinking about their own universal health systems. And Chris, drawing from your wealth of experience in various policy areas, but particularly in advancing women and girls, I wonder if we could start there and just ask you, how do you think gender factors into universal health coverage, and what should governments be thinking about?
Well, thank you very much. And I agree 100%. I think this is a perfect way to kick off the week. Maybe I should start by just offering the excuses of my minister who was invited to join you. As you can well imagine, Minister Monsef, who is Canada's minister responsible for international development, she is also, for those of you who are unaware, she's Canada's minister responsible for gender equality. So the good side of that is that this is the perfect conference for her to be at. The downside of that is I don't think there's anybody in greater demand than her right now as she tries to cover off both sides of her portfolio all day long, and she's pretty excited to be here, and she asked me to pass on my thank you for inviting her. Universal health coverage is something, it's a name, we use it on a regular basis. It's had various names over time and over history. To me, it's fundamentally grounded in two issues. It's grounded in a human rights-based approach to solving social problems. One that recognizes that, as Kristen mentioned, and I don't know if I can do a better job than her, I don't know about you, but I thought her opening remarks stole about 90% of anything good I had to say, is fundamentally built on the recognition that people, individuals all around the globe have a right to adequate standards of healthcare that they can afford. It's an aspiration, and it's something that all countries aspire to and want to get to. But it's also recognition that systems are required, that it is not enough to have advocacy, it is not enough to have rights demands and rights providers. You actually have to have systems in place to deal with this. This is something that requires a systemic, systems-wide approach to delivering on healthcare needs across a society, a large society. For the Government of Canada, we've recognized that one of the core elements, those two things put together, fundamentally hinge on questions of gender equality. So first, I don't see how gender equality is possible without attaining the health requirements that women and girls require. How can you possibly achieve gender equality if you're not having your health needs met? The flip side is that healthcare and health services offer the possibility to really make huge strides in gender equality. So they're a symbiotic relationship, I think. Maybe one of the things I would mention is that we all are keenly aware that the disparities and the inequities that exist across health systems and across health provision have detrimental effects on particularly adolescent girls and young women. And that's true right across. That's across all health outcomes, across all health issues. But it's even more important when it comes to some of the most core elements, particularly of adolescent girls' health, of sexual reproductive health and rights. For Canada, Canada has been a donor in taking comprehensive approaches to health, including health system strengthening, and it goes back to the mid-2000s in the MDGs and the recognition that in order to attain the Millennium Development Goals, health had to be a priority. Canada is, I believe, the last time I checked, among all the donors, we spend the second greatest percentage of our development assistance dollars on health. We have always prioritized, only the United States spends a greater percentage of its development assistance on health than Canada. And it's because we recognize that its fundamental importance to achieving all goals across what we're trying to achieve now through the SDGs. And maybe I'll leave it there, and I'll allow you to kind of move on. And,
Yeah, sure.
yeah.
When we were chatting beforehand, you mentioned finding that balance between that systems, that highly important systems approach, but also, of course, as a donor, wanting to reach the most vulnerable and the most in need of that quality care. So how do you, as a representative of the Canadian government, how do you think about that? How do you find that balance?
That's a really good question, and there's no answer. And in actual fact, I believe it's one of those core elements that you build into the way you think, right from the project level all the way up to the most strategic advice that I get. And my privilege is to provide advice to ministers to make decisions, all the way up to that strategic level. That you have to combine a very, I think, steely-eyed understanding that the individual projects and investment choices that you make have to be focused on the poorest, most vulnerable, and they have to produce results. Absolutely. But, and that often drives us to individual project discussions and to, ground local level issues, and that's great. But it has to be done in a way that furthers the broader goals of creating a system. Because without that systemic approach to doing business, we won't be able to actually reach the goals we're trying to achieve in terms of universal health coverage. So it's about always connecting those low-level, kind of investment-level discussions and decisions that have to be made with that broader strategy of recognizing it all has to be in the service of creating that system that will be built. And core to that is recognizing that gender equality and gender differences have to be built into that system. And those are the types of things I think you can get done at lower levels.
Great, thanks, Chris. When we're also chatting about this, we can't ignore the funding aspect, right? We need to find money to fund these projects and to fund kind of the greater goal of reaching universal health coverage in so many countries. So how do we close those funding gaps? And how is Canada working to do that, especially when it comes to women's health, women and children's health? Yeah.
So, not surprisingly, following the discussions that took place at Addis Ababa, the creation of the SDGs, there has been, I believe, a renewed focus on questions of financing. In a way that my experience in the lead up to the end of the MDGs really was absent. Canada was lucky to have been involved in a number of, I guess what most people would call innovative things. We did pull mechanisms, advanced market commitments. But in reality, what we weren't doing is taking systemic approaches. What we were doing was experimenting, and experimenting is a good thing. And if you hold yourself back from experimenting because you haven't figured out the entire system, then you're not doing it in the right way. But since 2015 and since the creation of the SDGs, we've recognized that across that spectrum of financing for development, donor countries, along with developing countries, along with the agencies, the local organizations and individuals, that we have to be working together to figure out across that spectrum, how do we get the financing where it needs to be. So a big element of this is obviously foreign direct investment. Private sector investment. Now, private sector investment is flowing into all places around the globe, but is it in furtherance of the SDGs? And how do we channel and drive more of that investment into developing countries in furtherance of and in reaching the most poor and the most vulnerable? That's a huge challenge. Last year at the G7, for those of you who may not be aware, I'm involved as well for Canada with the G7, and last year played an integral part in the G7 leaders' declaration on innovative finance, recognizing the importance of finding ways, and people in this audience, how do we get our pension funds, for example? How do we get our big funds of money to actually recognize that investing in SDG-aligned investments is a good thing? That will produce returns, but also advance work in developing countries. But then we run into this both in our own countries, but in other countries. Healthcare is more than just, it's a public good. In Canada, of course, we have a public healthcare system with all of its warts, its good parts, its bad parts, but it is fundamentally at about 60 to 70% financed through public financing. So we cannot achieve health outcomes strictly through innovative financing. We know that. And what does that mean? Well, what that means is donor governments have to step up. Donor governments have to contribute, particularly in those areas that require the most help, that are the furthest behind. In some cases, that means the poorest countries. In some cases, I think that means the poorest regions of countries, not just working in capitals. But it will require stepping up. The Government of Canada has always prioritized health, as I've said, and we intend to continue prioritizing health. But we need to do that in partnership, and that means domestic resource mobilization in health is critically important. And here I'll maybe give a bit of a shout out for the World Bank's Global Financing Facility. For those of you who are unfamiliar with the Global Financing Facility, it's an innovative financing mechanism, but fundamentally what its goal is to use World Bank resources to convince developing countries themselves to borrow for healthcare, to use the money that they can draw down on from IDA, the International Development Association, to invest it in their healthcare systems. Because right now they are underinvesting in their own health. So by providing that mechanism that gives an incentive to do so, it's one way that we can drive more public dollars into health.
Great, thanks. And I know that many of us were watching yesterday when Minister Monsef announced the Equality Fund.
Yes.
And so I wonder, what other innovative, you mentioned, the experimentation of Canada, of the Canadian government. What other innovative approaches are you taking in order to deliver more quality and equal healthcare to women and children?
So that's really we are living in an era in which I think the opportunities for innovation have never been so untapped. Whether it be through technology or whether it be through new methodologies such as design thinking, such as behavioral economics, we've never lived in an era in which there's been so much opportunity to try and do things differently. I work in a large bureaucracy, though, so this might come as a huge surprise to all of you, but large bureaucracies have real difficulties with disruption. We're disrupted all the time, but we don't like being a disruptor. We're built on creating the systems that deliver and move forward slowly, risk averse, and for the most part. The Government of Canada has been challenging itself to try and take on new ways of doing things. So, two ways. The Equality Fund is a good example of that, announced yesterday, a new innovative financing mechanism its purpose is to create a sustainable mechanism to provide funding to women's rights organizations around the globe on a sustainable way. But the government has also created new impact funds with new types of tools to do things differently, both in the domestic space and in the innovation and in the development space. That's to go alongside of our development finance institution. But to be, I don't know, I get these things mixed up, further to the left or further to the right, depending upon where you're sitting, more highly concessional than our development institution. So it's about creating along that spectrum, as I mentioned, of financing more opportunities. But we shouldn't limit ourselves there, I don't think. There's some fantastic ways of recognizing that there are other ways and other tools that are available to us than just more funding to do the things we always used to do. Maybe just one quick anecdote is behavioral science. So behavioral science is something that we're starting to have much better understandings of and better ways of approaching things. We've been involved along with the U.S. government in an experiment. And experiments are difficult in this space sometimes, and they're fraught with ethics issues, but they can still be done. But one of the core elements of behavioral science is that even if you know something is good for you, you don't necessarily do it. So we can create, and USP will do this, we can create the best supply chain systems in the world to deliver antiviral drugs and to deliver HIV medicines and whatnot. You're still reliant on individuals to follow the regime of taking the medication in the right dosages at the right times. That's a behavioral issue. So there are ways of working that's not just about money. There are ways of doing things and experimenting to ensure that all of that great medicine is not going to waste, because that's a core element of it. So we need to start thinking in the development space about how can we take on these new tools, the design methodology tools. We talk all the time about collaboration. Well, these tools are actually put kind of things in the hands of those people. It's not just coming together around a table. It's actually about recognizing that you can be led to creating those solutions that you need. And behavioral is another, data analytics, which my son understands that better than I do.
Thank you so much, Chris. I think we have to wrap up our chat. I
Sure.
really appreciate your insight, and I think that leads the panel into a great discussion, and I'm sure they'll continue that about behavioral science, about collaboration, and about how we kind of approach better equality healthcare for women. So I appreciate your time.
Thank you.
Yeah.
It was great. Thank you very much.
I'll ask our panelists to please join me on stage. I'll sit there, so Marianne, yeah.
I'm supposed to sit here so I don't screw up my microphone.
Thank you. Well, thanks for that interesting conversation to get us started. I am now surrounded by people who are working on the front lines of these very issues. So we are going to dig in a little bit deeper into how do health systems actually work or not work. Marianne Tibet is with us. Marianne, you lead MSD for Mothers.
Yes.
So you and the company MSD, or Merck, and as it's known in the United States, have made this huge commitment to maternal health. And I wonder, just to start you out with kind of an obvious question, but there are many countries in the world where maternal health is not that much of an issue, that these things have been solved a long time ago. Giving birth, we think of as a safe practice, something you can do, that's normal. Yeah. But then you look at other countries and the rates, including maybe my own, are not where they ought to be. Mm-hmm. So where do health systems fit in? I mean, isn't this a straightforward situation where we know the medication, we know the health regime? Well, why, as you try to promote this issue of maternal health, why do you need to think about systems?
So thank you for the question, Raj. And if it was a straightforward issue, hopefully we would have solved for it by now. I think that this is the conversation to have because it brings in many of these issues of gender equality to the fore. So the first thing around valuing women's lives. If we valued women's lives, we wouldn't have 800 women a day dying during pregnancy and childbirth, and we wouldn't have the rates of maternal mortality increasing in rich nations like the United States. In order to save for lives, that health system strengthening is important, but it's also thinking about the innovations that we need to support along the whole research development and, most importantly, getting it to the bedside that's going to actually help save these lives. Getting it to the bedside is critical to think about. And that's where the difficulties lie and the challenges lie around the health systems. If we don't have strong health systems that can get medicines to the bedside, it doesn't matter how good they are, they're not going to save lives.
So we're going to dig much more into that, but just when you talk about getting medicines to the bedside, I've got to think of the work that you're doing, Beth Yeager. You lead what is, I think, the largest foreign aid contract in the history of the world, which is the Global Health Supply Chain contract out of USAID, $9.5 billion contract, which is all about exactly what Marianne just said, getting medications where they need to go. Mm-hmm. You in particular lead the maternal health component of that and the Zika virus component. Mm-hmm. So what are your thoughts on this issue? Again, why is it so challenging? Don't we know how to deliver medications? Aren't there supply chains already? What is the big challenge we're facing?
Oh, goodness. I think it speaks a lot to the systems issues that Chris brought up. Yes, we know how to do it, but there are behavioral issues. There's the data issue. We're not collecting data to make sure that we know exactly where things are along the supply chain. There are human resource issues, and there's the big funding issue. You mentioned the Global Financing Facility, Chris, and there was the hope that the Global Financing Facility would take on a lot of the supply chain challenges, invest in commodity procurement, and what we're seeing moving forward is that's kind of dropped off the radar screen. So there's efforts now to try and get more energy, more financing, more attention given to the supply chain aspects, because it's not cheap. and it's not easy.
Yeah, just picking up on that, Global Finance Facility has a couple of challenges. One is their replenishment is only half the size of what they had hoped it to be. They wanted to be $2 billion, it's only $1 billion. Maybe that points in a way to the prioritization questions. What are our governments contributing? Do they see these as issues? And then again, to Marianne's point earlier, maybe governments aren't prioritizing, even with the funding they can get through an IDA loan. Are they prioritizing a regulatory environment? Are they prioritizing the supply chain systems? What do you see as you partner and work with governments all over the world?
Well, in short, we're seeing that many governments indeed do not prioritize these issues. And so while in certain settings there may be funding available, it's not going to supply chain investments, it's not going to procurement of the commodities that women and girls need. And I think that speaks to some of the issues around governance and stewardship and ownership of these issues and prioritizing women's lives and girls' lives and making sure that this is high on the priority list. Moving forward, in particular with UHC, I think there's a lot of strategic decisions that need to be made to achieve that aspirational goal. And what I'm seeing in my work is not a whole lot of strategic thinking going on. And another word that's come up is collaboration, and I personally don't like that word because I think it sounds very vague. But I think really working together and sitting down, even from the donor's perspective, and saying, what are we going to do as a community to make sure that the money we have, the small pots of funding that as individuals we may have, work together to contribute to a systems approach. And that requires systems thinking, and it requires the behavioral analysis that we've been talking about, and also data.
That's a perfect segue to America Winrocks, who is the Chief of Staff at the Global Fund, because you are, in many ways, that convener of many governments, of private sector, of civil society, and ultimately you're partnering with governments on the ground to make sure that in the fight against tuberculosis and malaria and HIV, the medications are delivered, the funds are there. You're in the midst of a $14 billion replenishment. How do you see it from your perspective? And you come at this from a career in the UN and across the development sector. How do you see it? Do you share the view we've heard so far, and how would you describe the systems challenge ahead of us?
No, absolutely. And I started working as a young medical doctor in South Sudan and Uganda, and just to highlight that the availability of commodities and drugs at the health facility is really key to the credibility of the system. And people only need to come a few times to a clinic and find the shelves empty. They will stop coming altogether. And so that availability is really critical, and the supply chain is critical. The Global Fund has invested a lot in supply chain, and I think in the current cycle, a couple of years ago, we really started thinking that we should take on a larger role on supporting supply chains. And I think we are a convener. We're not necessarily the organization with the mandate to really drive supply chain, but it became increasingly clear that it was a key risk to our mission. And if the supply chain is not working, if the medicines don't get to the clinics, to the local level, to the community level, it's really impossible to achieve results. It's impossible to achieve our mission. So we've started to become much more upfront and visible in the supply chain arena. And I heard that you don't like the word collaboration, but for me this is about collaboration, because the Global Fund, so we have a mandate that's specific to AIDS, TB and malaria, but we cannot build a supply chain that's specific to AIDS, TB and malaria. It's essential that we work with other partners, with the government, with other funders, to make sure that the supply chain that we're collectively supporting delivers all essential commodities, not just AIDS, TB, malaria commodities, but vaccines, drugs for other diseases, because otherwise, and in a way, I think in the early years of the Global Fund, in the early years of the HIV response, because there was no functioning supply chain, we might have been part of the fragmentation that happened in many countries, but we also take responsibility now to work much more collaboratively, supporting governments to support the supply chain that delivers everything.
Just to be clear, when you talk about fragmentation, I just want to make sure everyone understands. I think your idea there is there's been a long history in the development and health sectors where we come in, government of Canada or the United States or whomever, and builds a parallel system to the government in that country. And then when we pick up our stakes and go, there's nothing there left. And you're saying that was the case perhaps in the early days, but you feel like we're getting past it. Because I think part of what, Beth, you were getting at in talking about the word collaboration is what you said after, that you feel there isn't this strategic lens. And we would need that, wouldn't we, to make sure the funding for HIV or malaria contributes to a broader system.
Absolutely. If I just can add to it, I've been in global health for a long time. So at a certain moment, it's like you've seen a lot of things, but sometimes it's also very positive because you see the progress that has been made. And for people who have been in global health for a long time, you might remember some 10 years ago, the supply chain system in Kenya was always used on a slide to illustrate the fragmentation in supply chains in global health. And it was like a bowl of spaghetti. You had all these different donors that had their own supply chain, and it was very confusing. And Kenya, I think now, 10 years later, has, I think, one of the most advanced supply chains in the world. There at KEMSA, we have an inspector general who's auditing programs. They're really critical, and the supply chain audit in Kenya was one that came out entirely green, like very well covered, very well functioning. So we have made progress. We can make progress.
How do you see it, Marianne? You're looking across many countries in your work. Where's the progress? What's the situation?
No, and I actually like to bring two concepts that we've started to hear at this conference to bear. The one around power. And how is it that we use our different powers to put women in the center of this? One of the things, how many of you guys think supply chain is sexy? Yeah? No one does. Well,
the woman who's leading it thinks it's sexy. We need that.
How do we keep the interest, in this issue and incentivize people to care about it? And I think we need to not think about it from a top down. We need to think about it from a bottoms up. We need to put women in the center of the supply chain, not as the recipient, but at the center. We need to support them in demanding, for those high quality medicines that they and their families need. And we need to give them the data so that it's not just random, qualitative anecdotes about things not working. But anytime, any of us, can go online and see whether X medicine is available at X primary care facility, for the women who are traveling half a day to get there.
Is that happening now in any way?
So thank you for the question. I mean, one of the experiences that we've had in our MSD for Mothers partnerships is a supply chain partnership in Senegal with the Gates Foundation, where we integrated local private providers into the public health supply chain. And what we found, because we incentivized, or the system incentivized those private providers by making sure that there was real-time data available and that they were paid when the medicines actually got to the facility, we saw 2% stock-out rates, down from 80% in some facilities. It was so successful, the government scaled it up to all districts in the country and expanded its remit from not just family planning supplies, but 100 essential medicines, including some of the Global Fund essential medicines. But we are at a critical juncture in that project because now we're looking at the issue of sustainability.
Meaning who's going to pay for it when Gates goes away?
Who's going to pay for it, but who's going to keep up the pressure to pay for it? And how are we going to get that data visibility so that we understand what's happening in real time, and how are we going to arm women, to be advocates for this?
So that's the connection to this issue of power.
Yes.
That if the woman at the end of the day in that last mile situation, if she doesn't feel power to voice her concern that, hey, there's stockouts happening in my local clinic, then who's going to make this an issue at the government level?
And just to add to that, it's, when we talk about power, it's not, or choice, it's not about having the choice. It's being able to exercise that power, and having that power, or having that voice actually be part of a solution and integrate it into a system. So it's no good for people to say, we don't have the supplies here, unless that information is being actioned on by the folks who are responsible for that. And so, when we talk about health system strengthening, we need to make sure that women's voices, women's solutions are integral to how we strengthen health systems. And back to my point about women need to be at the center.
Beth, we've heard now two examples of countries where things are going better, Kenya and Senegal. But both of those are middle-income countries, relative stable countries, lots of advantages, let's say. But in a lot of the countries where we have high prevalence of malaria or TB or HIV, the countries where you're working through your supply chain project, you may not have those circumstances. Are we still building in the fragmentation we heard about earlier? Is that the only kind of short-term path? Or are there other ways to work in the maybe 20 or 25 countries now in the world that are so fragile, so unstable, and where, you know, the last mile, the most vulnerable people are likely to be left?
I think that we tend to talk in one-size-fits-all terms many times. No, when we're sitting at these events or we're sitting in Washington, it's like we need to do this very neat solution. And I think you brought up an excellent issue because there is no one-size-fits-all, right? And we all know that. And so I think there are some settings where, yes, that fragmentation still exists because of the need, because donors also want to make sure that the commodities that they've invested heavily in are actually getting in fragile states or in difficult situations to the communities that they were meant to get to. So I think there is that. But I also agree with your point that we have come a long way and there is increasing recognition that this isn't going to work. And as donor contributions potentially diminish and countries are required to fund supply chains and procurement of medicines with their own national resources, that it doesn't make sense to have fragmented supply chains necessarily. And so I think we're in a state perhaps of flux, right? Where you've got contexts where it does make sense for donor-funded commodities or whatever to have these vertical supply chains. But in other situations, no, we're moving towards seeing how we can economize. And I think, it's related to the conversation around investments as well in strategic thinking. Funds are limited and they're going to be limited moving forward. They've always been limited, right? Donor funding may increase, it may decrease, who knows what's going to happen. And so we need to help as a community, I think, countries really make these strategic thinking decisions and smart investments.
This is a big part of the argument I know that you and your colleagues are making around replenishment, is that governments need to step up as part of the replenishment plan. You're expecting them to step up in a bigger way to pay for the systems in their own countries. How do you see this conversation as it's evolving now, especially in the lowest resource settings?
I think even in the lowest resource settings, most countries have the ability to fund more in health systems. And we have to work with Ministries of Health and the Ministry of Finance, with other funding partners at country level to make the case and for increased funding of health. So I think there's more countries also than Senegal and Kenya where we have made progress. Political leadership is incredibly important. Just think in countries like Rwanda and Ethiopia that have politically very strongly focused at the primary care level and made significant investment in making sure that the health system close to the community is functional. And so there's political leadership is incredibly important. And we ask increased contributions from donors, but we ask for even higher increases from the countries. And so we looked at the potential for economic growth. We looked at fiscal space projections in a couple of countries, in all countries in the portfolio, and we think there's absolutely the opportunity to invest more. And we had an interesting session at the World Health Assembly co-hosted with ministers of health from Botswana, Zimbabwe, and Eswatini. And the interesting thing, it was to support global fund replenishment. They all appealed to donors, but they also said, and we will step up our domestic funding for health because we realize that we have a role to play. We have to demonstrate results. We have to step up funding. So I'm pretty positive.
Yeah, that's a really big point that I think I just want to underline for a second. The idea that you've done an actual analysis of this and you feel there is fiscal space. There's room in the budget to invest more, even in poor countries. And that some of those governments at least are stepping up and saying, we will do that under this reply. That's an important point. Marianne, you wanted to jump in.
Yeah, no, thank you. But I think sometimes we fall into the fallacy that the only folks who can solve for this are donors and government. There's a whole private sector. There's a whole continent of people looking for jobs and, social entrepreneurs hustling for business. How can we think, Chris, you talked about innovative financing and using that to spur sustainable solutions and sustainable models. How do we think about bringing local entrepreneurs into this space and catalyzing their growth, so that they can be part of this solution and, the on-the-ground dynamics around supply and demand and market forces, I think are things that we haven't really brought into the supply chain conversation. And I'm excited to see, with these new innovative financing mechanisms, including the Global Financing Facility, facility of which MSD from others is a contributor, how can that spur local private sector solutions that can complement efforts of government and donors?
Can you give us some examples around that? Because I think it's still amazing to me how far we haven't yet progressed on that conversation of private sector role. It's still often a political or ideological conversation as opposed to a practical one. In most of the countries we're talking about, you mentioned Kenya, I think it's like 2/3 of healthcare spending is out-of-pocket spending. So, people, many of whom are under the poverty line, going to their clinic, going to their pharmacy, pulling out hard-earned money to pay directly for their health services. So give us some thoughts on how exactly, Marion, do we get to the point where we're empowering the private sector or social entrepreneurs to be part of the solution?
So I think it's not easy, and we're actually in a space of experimentation right now. But again, if any of you have gone to any of these facilities, I'm from Nigeria, and you go to public sector facilities, most of the time you'll be told to walk down the street to the private pharmacy and buy your supplies and medicines there. And we know in the case of maternal health, USP has done studies that have shown that critical medicines to save women from postpartum hemorrhage, and 70% of those are of poor quality. So back to your question about how do we do it, we did do, we are in that midst of the experiment in Senegal, where private sector logisticians, were integrated into the public sector supply chain. I think the challenge is that many of these local private sectors are small. They don't have a Chemonics budget, and many of them don't have a 5-year, 10-year history, of doing this work. And I do think it's us donors, and I put MSD from others in that space, we have a very low risk tolerance, for investing, in these new enterprises that either don't have the size, reach, or longevity. You mentioned we are concerned with, we do want to make sure that our investments have impact. So I think it's up to all of us, especially now where there's a lot of innovative financing kind of going into this space, to think about how together we can reduce the risk of investing in local private sector.
By the way, one of the things private sector tends to get right is something Chris brought up earlier, which is behavioral science. Another fancy word for behavioral science is marketing, right? And a lot of companies know how to do that and get people to buy their product or use their product, right? So there is an actual skill set expertise out there that we might want to tap into. Sorry, I thought you were trying to jump into to that discussion. Please go ahead.
I was nodding very enthusiastically. No, absolutely. And so we're working, we have really scaled up interventions for adolescent girls and young women in sub-Saharan Africa. And one of the things that's really critical as you develop programs, that you really put the girls and young women at the center and let them be part of the design. And so there's approach human-centered design, which I think in development, in the aid business, is very innovative. But that's marketing, but the companies have been doing all along. So I think we can learn a lot from companies from the private sector in that perspective. We can also learn a lot from companies when it comes to supply chain. Because all the big companies, they manage to get their products to the lowest level to all the communities. And somehow we have not managed to do that as a public health community. So there's all sorts of collaboration with private sector companies that you can think of.
Yeah, we've all experienced that. You go to the most remote village, and yet you can still buy a Coca-Cola or a product from P&G or Unilever.
And it's cold.
It's cold. How do you see this? Because you made an interesting point earlier on about saying that you just don't think there's a strategy. And we're hearing kind of elements of this strategy, right? We need to engage the private sector in terms of implementation. We need to engage innovative finance mechanisms. We need to get past vertical approaches, not just HIV or malaria, but think about systems. We need to get governments to kick in their own money. But yet, somehow you're not seeing that, and you're doing this in many countries. So what are you actually seeing on the ground that's so divergent from this kind of maybe big picture strategy we're starting to sketch out?
Well, I think what we're seeing is separate initiatives that are happening at the country level with no single entity sort of stepping forward to be the ringmaster and pull it out all together, right? So I think we're seeing a lot of interesting innovation. We're seeing a lot of progress. I think oftentimes it too is fragmented according to sort of the health area that it's addressing. And I'd just like to pull us back to the private sector conversation as well. In terms of maternal and child health, which is my area of specialty, the private sector is already engaged. They are engaged because typically governments are not procuring MNCH commodities. And so the private sector is right there. As you mentioned, Nigeria is a perfect example. We're currently working in 3 states, 2 in the north of Nigeria and 1 in sort of central Nigeria. And that's what we're seeing. Health facilities are completely stocked out of MNCH commodities. And so women or their husbands or their mother-in-laws or whoever are being forced to travel down the street to the local drug seller who is selling who knows what. Because
and is it
talk about
unscrupulous
the
providers? Is that the reason
No,
people
it's
try
not.
to save money and make money so they're not, their oxytocin is, you said 70%
No.
were low quality? Or?
No, I think there's a real issue of lack of awareness of what quality is. And so when we talk about engaging women so they can demand quality products, what is quality? Those of us who live in Canada or the US go to CVS, go to Target, I don't know what the drugstores are called in Canada, and we trust that what we're getting is a quality product. We don't, like, how many of us actually check the expiration date? I'm channeling Lawrence Evans here. He would be so proud of me. But how many of us check an expiration date? No, we trust that what we're buying is going to be good quality stuff, and women don't have that luxury. And actually, I went to a local drug seller in PPMVs. I can't remember what the acronym stands for. It's very complicated. Whatever.
Proprietary and
Thank
patent
you.
medicine vendors.
That.
Yes.
And I was able to procure, I bought oxytocin. I bought misoprostol.
Yeah.
The misoprostol had no expiration date, and the manufacturer was not listed at all.
Yeah.
And so these basic elements of quality are missing. I don't know where I was going with it.
As an individual consumer, there's nothing you can do, right?
No,
I mean,
unless you know what you're looking
Yeah,
for.
unless we support the
Exactly.
individual consumers. I do think we need a campaign around how quality of medicines needs to be an integral part, and Gachindi is here, of the quality of care agenda, which needs to be integral to the universal healthcare coverage agenda. And we need to arm women, with this information. You asked the question about, is this scrupulous or unscrupulous? If we are able to support providers, they will do the right thing. One of the other projects we're working around the PPMVs, because we recognize, that 60 to 80% of women are getting critical medicines from these suppliers. So instead of trying to, say, we don't agree with that, disrupt everything, go here. Let's work with what actually is happening on ground in local systems. And so another one of our partnerships with Gates is to improve the quality, of service that these PPMVs provide, and working to integrate them into an accreditation system, so that at least consumers can say, okay, well, this PPMV provider has been accredited by a government regulatory agency, and I can have some additional level of trust that they know what they're doing, and that the medicines that they provide are high quality. So, we're working with what's there on ground and trying to improve it, as opposed to saying, we have a better way of doing this.
And I'm taking from the way you're describing this that that's unusual, meaning there still are lots of examples where the global health system is saying, we don't want to pay attention to the private sector providers. We wish they weren't there. We wish there was something else. Is that how you see it, Marika? Do you see that too, in the sense when you're looking at these systems that, again, you've been around the global health world.
Yeah.
So does this ideological divide or this kind of worldview divide still persist?
It still persists, but I think it's, if you look at the very ambitious SDG 3 agenda, I think there's no way to remain in our silos and still achieve the targets. And I was just thinking, I was discussing engagement with private sector providers. In TB, every year we are missing like 4 million people who are living with TB, who are active infections, and who don't access health services or don't enter the system. And a large proportion of these, especially in Asia, a large proportion of these people, they access private sector providers with quality that's variable. And especially the poorest people are the ones that will most likely access poor quality private sector providers. And because they have to, so the quality of the medicines is not always guaranteed, and because people have to pay every time they come back to the clinic, at a certain moment when they feel better, they only have incentives to stop going back because it costs them a lot of money and they have to pay for the drugs on top of it. So in a couple of Asian countries, we've started to work with the government to engage with the private sector. And we had our kickoff for the replenishment meeting in India, so I visited some of those clinics. And that's a collaboration between the public health sector and the private sector providers, where the clinics, they share their information with the public health so that we have the patients, the information. But also the people that register with the private facility, they get the medicines for free. They get vouchers so that they don't have to pay for the medicines. And I think those are the sort of solutions we have to think about, because it's otherwise it's the people who are most vulnerable, the poor, the women, marginalized groups that are the ones that most likely to suffer from poor quality healthcare.
And to underline, because you gave this stat before, it's pretty arresting. 70% of the oxytocin is low quality. That is literally life or death, right, for a woman in childbirth.
Yeah, it is, and that's why 98% of the postpartum hemorrhage, which is bleeding after childbirth deaths, are happening in low and middle income countries that don't have 24/7 electricity. Because oxytocin needs cold chain, it needs to be refrigerated. I see people nodding. It needs to be refrigerated, all the way through the supply, distribution, and storage process.
And we want to get others into this conversation. So in a moment, I'm going to be looking at you, pointing at you, hoping some of you are ready to jump in with provocative questions for all of us. We've got microphones in the room. So we'll get to that in just a moment. But I want to continue just for a second on this broader conversation. What do you think we're missing so far in this discussion, Beth? What is there that, when you're out there meeting with your counterparts in country, you're dealing with this large contract that's tough to implement. Does this conversation resonate with the challenges you're dealing with every day?
Oh, absolutely. Everything we're discussing now, I was thinking, how do we organize this? Because we're kind of we're venting, right? This is cathartic. I think some of the issues we may not have addressed completely in this conversation are the challenges with decentralization, as procurement functions are being now pushed out to lower levels of the system. And the worst example...
Do you mean like Kenya, decentralizing government? Or
Yes.
do you mean at kind of the global health
No,
level?
decentralization within a country. And so the worst example I can think of right now is what is happening in Nepal, where previously you had procurement of maternal and child health commodities and other commodities happening at the central level. Just this year, those functions have been given to 754 local level governments. So imagine, 754 people are now responsible for procurement of oxytocin for the 12 health facilities that they now are in charge of. And where are they buying it from? And what do they know about quality? They previously had been procuring probably fertilizer and notebooks and pens for their local governments, and now they're responsible for the health of women and children. And that's very scary for many reasons.
Do you see this more broadly than Nepal? Do you see this happening in other places?
It's happening in Nigeria as well. States are responsible for their procurement. Ghana, Kenya as well. So it's a tendency right now in the context of universal health coverage as well. It's something to think of.
Issue, we had the conversation about vertical programs.
Yes.
One of the reasons the maternal child health commodities have the lowest, in-stock rates is because most of the time the procurement is decentralized. The facilities procuring, the local government's procuring, the state is procuring. I do think, and to your point, we should not leave this room without a next step around how we start to solve for some of these things, because I do think the pieces are here. The financing is here, it's ready, to be mobilized. I think that the data, is there. They're not connected, and it's not going to be easy to connect them. But the way that we can solve for create some of these economies of scale and reduce transaction cost and ensure that we are getting quality medicines to the bedside, to me, is around data transparency and data sharing. If we can focus, on how data can flow between public and private sectors, between the consumers and the healthcare providers, between the funders and the implementers. I think we will go a long way to creating some of these economies of scale and reducing transaction costs and getting the information to the woman at the end so she can be empowered, to fight for what she needs to stay alive.
How do you see that flow of data actually happening? Is that a kind of a global set of standards? Or is it at the national level where governments, because data is a provocative question nowadays, right? Like what happens to data privacy?
Yeah.
And I think we all know, working global health, the quality of data is often very, very low, what exists already today. So how might we begin to tackle that problem?
So the building blocks are there. I think it will create, we need more advocacy around data transparency and the way that data transparency can actually accelerate progress to all of this. And we need some key governments and some key donors to step up and say, we're going to share our data. And show that we can do this, and we need that trust, to be able to do this and demonstrate that it's impactful. But I do think it will take some people stepping up in front and saying, despite all of the issues, we're going to figure out how to solve them, but we're going to have transparency around how commodities flow and how the financing for commodities flow.
So I want to turn to all of you and see if there are any people here who want to intervene with a question or a comment, something we're missing, a perspective that you'd like to add to the discussion. Does anybody want to jump in at this point? Okay, got a couple there. We'll bring the mic, and we'll take two, or maybe three if there's a third over here at a time. Go ahead, please.
Susan Mitchell, Apt Associates. I'm interested in the questions you've brought up about quality of drugs in the private sector and what solutions or innovations you see out there that might help address that challenge.
Great, and if you could pass the mic to the back there.
Hi, Judith McCord from Project Concern. Two things. I think we've had a fairly disease-specific conversation, and I think it's really important to talk about other commodities like contraceptives. So I'd love to hear, maybe Beth, from you about work in contraceptives. I know the U.S. government has been an enormous contributor in that realm. So I think it's just important as a very important intervention for women and young girls. And the other thing, Marika, maybe you could say a few words about cervical cancer and the emergence of some new commodities in that realm and how critical that supply chain will be.
Great, thank you for both of those. Was there another one here? I think on this side. Pass the mic there. Take a third.
So thank you very much for that presentation. I come from Kenya, and I just have a few comments, and some of them would be like questions. Even as we talk about availability of medicine, one thing that comes to mind is how do we create demand for the particular products that we have, because even if these drugs are actually there, we have a number of girls and women who are not even aware what is available for them. In terms of data demand and information use, how do we empower communities to also be able to utilize that data to do advocacy at grassroots and really hold governments accountable? And then also, even with availability of drugs and all these services, how do we work with providers to also change their attitudes towards especially adolescent girls in terms of accessing key services like contraceptives? And finally, how do we create an enabling environment for a woman to really utilize the power that we keep telling them they have? But I think when we talk to adolescent girls, they'll clearly tell you, I don't have the power. Someone else decides for me which service I will take, what products I will use. So how do we create that environment for them? Thank you.
Thank you very much for all of those excellent questions. Let's start maybe, Beth, with you, with Judith's questions. She said we're having a very disease-specific conversation in many ways and wants to know what about thinking beyond the individual disease? We've talked about specifically contraceptives. Mm-hmm. What are your thoughts on that?
Well, I think everything we've discussed so far very much applies for contraceptives. I think we are seeing in a number of places the need to really increase domestic financing in the very near future. And so many of the issues we've discussed, even around quality, are going to be even more important in the contraceptive family planning space moving forward. As a matter of fact, I was at the Reproductive Health Supplies Coalition meeting in Nepal, and I don't know if anyone from the RHSC is in the audience, but they've been going through a process of looking at the supply ecosystem towards 2030 and what will need to happen in the post-SDG era as we see diminishing donor investment in family planning and the need to really increase domestic funding. And so I think much of what we've seen, particularly in the maternal and child space, moving forward is going to be extremely relevant for family planning and contraceptives.
And I think cervical cancer was the other point Judith brought up, particularly for Global Fund. What are you doing on that now? What's the opportunity?
And thank you for giving me the opportunity to do advocacy on cervical cancer, which I committed to yesterday. And starting with the discussion with the question of contraceptives, because what the Global Fund, the focus of Global Fund now on strengthening the supply chain is supply chain for all commodities. It's not disease specific, and that includes vaccine, contraceptives, anything else that people will do, will use. And I think it links to the cervical cancer because I think at the end of the day, it's all about meeting the needs, the specific needs of people as they're accessing health services, and that cannot be done in a vertical way. And as we had a discussion on a meeting on cervical cancer yesterday evening, and I talked about the as HIV has become, for most people who are accessing treatment, a chronic condition, they will engage with the health system on a regular basis, and that means that the health system has to respond to their needs as they are engaging with the health sector. And that's not just HIV specific, because the HIV is only a small proportion of somebody's life. People have other needs for contraceptives, for other medicines if they have other conditions, for prevention, for health promotion. So it's very much about providing the sort of integrated care that deals with all of these issues. The Global Fund, we do support cervical cancer screening as part of HIV programs because of the disproportionate impact HPV has on women who are living with HIV, even if they're on treatment. The uptake is still lower than I would like it to be. So I think it's coming back again, just to link all the questions on the demand creation. I think the awareness on some of these issues that are very much part of people's lives. Cervical cancer, the awareness around the importance of screening, how regular screening can really avoid can really promote early detection and treatment at a stage where it's still possible. There's still a lot of work to be done. It's good that awareness around cervical cancer is increasing. There's still, it's a disease that's preventable now, largely preventable with very effective vaccines that are available. Prices have come down. Early screening can prevent a lot of women unnecessarily dying from cervical cancer. So there's advocacy movement is growing, but still sort of it's in early stages.
You're saying even in cases where you're financially supporting the screening of cervical cancer, women coming in for HIV treatment are just not, they don't want to get screened.
I think the awareness is not there, and it's among the women, a lot of women themselves. It's women living with HIV, they have known for a long time that cervical cancer is a condition that kills many of them. And so they're now alive because they have access to treatment, but still they should be screened at least annually for cervical cancer. And I think we have to build the awareness also among the health providers.
Marianne, maybe you can pick up on Susan's question about, we talked a lot about low quality medication and the role of the private sector in that. What are some of the solutions?
Sure, and I'd like to link it to the lady who asked about family planning. So about 30% of the MSD for Mothers investments are in family planning. We know if we address that unmet need, maternal mortality burden reduces by 30%. And then also the lady from Kenya, I don't know, what's your name? Patricia, do you know about a platform called Nivi? If you don't, that's fine. We'll talk afterwards. The reason I brought it up because I think it's one of the ways that we're trying to get to some of the questions that you raised. How is it that we can get the information, to young women and men who need it and actually respond to their needs? So NIVI is a digital platform that has been marketed as a family planning, information tool to women, where they are able to ask questions to a chat box, which is not a real person, as I've been told, and artificial intelligence answers the question. So again, you don't need this to be manned by humans, and we can ultimately scale it up, at low cost. What we found, and there are now, I think, over 85,000 users, it was just launched late last year, is that, first of all, 17% of the folks asking question were men. That was something that totally surprised me. The other thing, as I said, it was marketed for family planning, but almost 40% of the questions that were being asked were outside of family planning, were in that whole, sexual reproductive health continuum. People were asking about PrEP. People were saying things like, if I take this family planning product, will I get cervical cancer? There were lots of myths that were recognized by the questions that were being asked. But even more importantly, opportunities to now correct those myths and preconceptions, because artificial intelligence is intelligent, and so it can nudge, using behavioral science, the users to ask the right questions to get to the right answers. The other thing that's exciting about NIVI is that it asks questions about preferred methods and characteristics. So, for example, if an adolescent wants a long-acting method, that information gets transmitted to the provider so that the conversation, when they have it face-to-face, doesn't have to be limited by anyone's preconditions or stigma around what types of options, should X person get or Y person get. And so I think, again, there are promising ways, to solve for some of these things. One of the reasons I'm really excited to be at this conference is because there's so many young people here. And I want to ask the question about, is digital a promise? Are we getting it in the right hands? What are the barriers, of getting these new types of innovations to folks at the last mile? Are we asking the right questions? So these are all of the things that can improve on our, real-time experiments, to make real connections with young women.
And it's important to remember, I think, that the ground is shifting beneath our feet. We can have this conversation, and the big global health and national government institutions can have their slow, steady change. But there is rapid disruption happening in the technology space and on the consumer side. So as these new products are being developed, customers say, I want that. I want easy access to it. I want to skip around the current process to get to it. And we're not many years away from ubiquitous high-speed internet connectivity, including in very low resource settings, from pretty advanced artificial intelligence platforms provided maybe by total private sector operators that we have no control over. I was just in Rwanda and went and visited the Zipline facility. Zipline, for those who don't know it, is a drone delivery system for blood. And they've launched in Rwanda. Now they're moving to Ghana. They're actually opening an operation in North Carolina in the United States. But they're moving really fast. They were just valued at over $1 billion. They're a unicorn in Silicon Valley parlance. And that is not because they waited around for a new set of standards or a new coalition of donor agencies. They basically just raced to the market with one partner government, a key one in Rwanda. But the ground is shifting very, very quickly. And I think Patricia's point is that, in the end, the local communities, they want access to this data. They want to feel empowered. They want to be able to make their own decisions. And it seems like a complex moment in which to have a discussion like this, given how quickly things are shifting.
And I think, to me, it's really interesting. Are we building for today, or are we building for tomorrow? And I think when we think about building for tomorrow, we should be more comfortable with taking risks and being comfortable that we don't have the answer, and being able to say, yes, phones are not in everybody's hands today, but maybe in 5 years they will be.
And wearables and
Yeah.
sensors and everything else. Marika, I think you wanted to jump in
No,
on
I,
this
I
point.
think we have to accept a degree of disruption in the health sector, and I think that's really healthy and very positive. And I'm just coming back that the point that Kristen made that really resonated with me, that universality doesn't mean uniformity. I think uniformity is where we are. It is probably very often the norm because it's sort of easy. You have norms and standards and you just implement it, but that's where we are spectacularly failing women, young people, even men in providing health services. And the stigma that you talked about, I heard it because for a lot of, young women accessing health services for contraception, they're very often faced with stigma and very judgmental behavior by the health providers. But there's other products that are stigmatized for women. And like pregnancy test, misoprostol. So there should be, and I know there's, I think it's again Kenya, where there's like an online pharmacy almost, where women can buy those products online and get them delivered at home or somewhere else where they can collect them. And it doesn't come in a box saying what it is, but it provides. So I think that's sort of really person-centered, really looking at what does a person need and respond to those needs rather than have very uniform approaches that are usually simple but will fail.
That's again that behavioral science approach, right? Thinking, meeting the patient, the woman where she is, and understanding, her needs. Yeah. Did you want to jump in on this point about the ground shifting beneath our feet? I'm just curious.
No, I think you're absolutely right.
I mean, you're out there developing supply chains that are meant to last for a long time, right? I think the supply chain contract you're working under is 5 years, 7 years?
It's 5 years.
It's 5 years. So you're thinking about a period when wearables and connectivity and all of that. Are we building for that future, to Marianne's point?
Again, I think we're in different places in different stages in different places. No, I think the short answer is probably no. I think there is a lot of resistance to disruption, resistance to, or a low risk tolerance. But like you said, the private sector is charging ahead, right? Other groups are charging ahead. And so I think we are at a very interesting phase in global health.
So Raj, one more point.
Please.
Oh, no,
And I do want to go back and see if
finish.
there's anyone else who wants to jump in.
And just before I finish, and that's why this aspect of governance and strategic thinking and stewardship is even more important because yes, those products will be delivered to your home. Who is assuring the quality of those products? And this is another point I wanted to make. Oops, sorry, you talked about supply chain not being sexy. The least sexy aspect of supply chain absolutely is the upstream supply chain stuff that USP works on. Again, getting brownie points for Lawrence here. Regulatory system strengthening. That is a long-term game, and you can ask anybody from USP about that. And it's not sexy because you don't see an immediate results. There's nothing sexy you can do. It is what it is. And speaking to the question that the woman from APT asked about innovations, there are some innovations, and I will invite you to go take a look at them at USP's booth. There are some rapid test tools that are currently available to check the quality of medicines on site. They're not currently, and correct me if I'm wrong, people from USP, they're not currently able to detect quality issues in a wide swath of medicines, but at least they're available. There are other platforms where if you are an informed patient or client or whatever, and you go to a pharmacy, you can check on an app if that product is actually registered in country. And so there's some things going on in that space for quality assurance, but I think in general terms, it's an area where we haven't done enough, I think, and it's so essential. Yes.
No, thank you, and I apologize. I didn't mean to interrupt. I just got so excited about, we are talking about digital and linking to the consumer. There are a number of donors in this room. Why don't we fund the consumer? To buy the product that is quality assured, that we know is coming from the right place and that can get to him or her immediately. So I'm just excited, even if you think about this NIVI platform, if we put, financing in the hands of young women, to get critical family planning products from accredited providers that we know are quality assured, that will drive the market and I think will incentivize folks to be part of a quality assured health ecosystem for critical supplies.
That idea would have sounded nuts just a couple of years ago.
Yeah.
It would have, because you say, how do you put money in the hands of consumers?
We need to.
But one of the things I talk about in my book is retail aid,
Yeah.
the way I describe it, that we're moving from a wholesale perspective on aid to retail. We can now actually identify that consumer.
Yeah.
We know who they are. We can talk to them, find out their needs, and directly provide
Yeah.
mobile money. I think in Kenya
Yes.
now,
Yeah.
97% of households use
Yeah.
M-Pesa, which includes most of the country's people living in extreme poverty, even they have access to it. So this is something that might have sounded just absolutely off the wall.
But it's exciting.
Just a few years ago, and could be truly possible that
Yeah.
we don't just have to fund providers, can directly fund the most vulnerable people in the world, the most marginalized people in the world. Others want to jump into the discussion. What are we missing? Gitinji Gitahi is here in the front. I see a couple others in the back. Oh, great. We're provoking some real interest. Let's pass the mic here. We'll try to take all of your thoughts if you can keep them short. Please.
Okay. Thank you very much. My name is Fatih. I come from Ghana. I've enjoyed the discussion so much, but I want we, the women, to take we should take into consideration that most of the women we have in Africa, especially in the rural communities, are not educated. Most of them cannot read and write. So when we even talk of diagnosing or even reading and knowing that this drug is expired, it's even a very serious issue. And for that matter, we should even insist on the health workers to do a campaign or meet the women in the communities at the district level. The nurses, we should all get involved. The nurses, the doctors, the health workers, they should get involved in advocating on some of these problems, on the menace of expiration of drugs, and maybe even doing breast cancer screening, cervical cancer screening. All those issues are problems that we are facing at the rural communities with the women. Most of them are not educated. So when we are talking, we should realize that we are talking for all women, not only those who are educated.
Thank you.
Yes.
Thank you for
So
raising that.
that's why I just want to make it a point. And in Ghana too, we have this health insurance in place. So we should insist that the governments should enforce that the policies work. They should enforce that the policies of the health insurance work, other than relying on private sector. When they go, some of the illiterates, when they see you carrying drugs, they just say, oh, I'm having headache. My stomach is paining me. So if you give them the drug, they will swallow it. They will just swallow it. Whether it's paracetamol, whether it's good for the sickness, they don't mind. They just feel that, oh, once it's a drug, I can take it. They have no what do you call it? They can't diagnose anything. They can't read anything. They don't understand the dangers of abusing drug. So when we are talking, we should not just zero it on our levels. We should remember that we are going out there to meet the larger women groups at the rural communities who cannot read and write. And we should not just leave it. We should know that we have to do a very big campaign. It's a very big thing we are discussing. Even sometimes when you go there to do cervical cancer screening, you have to involve the chief for them to convince some of them to come out. For their own benefit, to come out and do the screening. The breast cancer screening is you have to get somebody from the community that they trust to now give them the opportunity to do the screening. Otherwise, they won't come out. So we have a lot of work to do when it comes to health matters. Even with the educated ones, as we said, how many of us go through the drugs before taking? We don't know whether it's expired. And you can now imagine somebody who cannot read and write. So it's a very big thing we are discussing. We should make sure that our governments do the right thing. The government, those involved, the stakeholders, those who are the policy makers, we should make sure that they enforce that the right thing should be done. So that we don't just leave them and say that they should go to, when they go to drugstores, if you ask them to go out there to the private listen, when they go, they give them even a substitute. If this drug is the best, they will go and say, oh, we don't have this one, the one that they prescribe for you to buy. But you can get the substitute. Probably the substitute cannot solve the problem. So we should reconsider all these things and then
Thank you for bringing that ground truth
look
to
at
the
it at the
discussion.
broader. Thank you.
Thank you. Thank you. Can we pass the mic right here to the front? It's on. It's on.
Thank you so much for the inspiring talks. I'm working in neonatology research in low resource settings and running a project where we're looking at quality of care. And what I think so much about is that how do we empower the mother who's in the delivery room to, her voice is so low, she doesn't know she has the options to go to her member of parliament, to go to the pharmaceutical company, to go to her healthcare provider and demand that the minimum resources in the room, that there is an ambu bag in case the baby needs resuscitation, that there is the drugs in some quality that have been stored, they have a generator at the hospital. And I'm just wondering if you have any ideas on how do we make sure that the mother get the empowerment, even though with low resources, with low literacy, to actually demand that quality that we take for granted when we deliver in the West.
Thank you for that. And we had a couple in the back as well. Again, if you can keep them brief, we'll try to take all of them.
Hi, thank you all so much. My name's Jennifer. I work with Medica Mondiala in Germany, and we're working with health professionals in conflict and post-conflict countries, and training health professionals on how to meet the needs of survivors of war, rape, and sexualized violence. And I'm really interested in this behavior science. And I'm wondering if you guys have any ideas on how behavior science can be used to work with the attitudes of health professionals to decrease stigmatization. So that's my question. Thank you.
Great question. Just pass it right next to you.
Stephen Kimatu from USP. Previously, I worked as a product QA manager for the Partnership for Supply Chain Management. One of the biggest problems was the 2 to 8. So I just want to hear from Chemonix and Global Fund. What basically are you doing, especially in-country supply chain, that to make sure that these products, especially oxytocin, is between 2 to 8. From the supplier to the country, I can assure you that that's monitored. It's not a big issue. The issue is when the product is in country. Lastly, as Beth said, the USP demonstration will be at booth 25. We'll be doing the demonstration today 1:15, 3:15, and the other days 10:15, 1:15, and 3:15. I'll be the one doing the demo. Welcome.
Great. So we can actually see how we can test the medicines in real time. That's great. I think there was one more in the very back corner.
Thank you. Hi, Elaine Scudder, Save the Children. Just drawing attention to the fact that the conversation has not addressed the humanitarian and fragile country situations yet, and the realities of things like delays in being able to get narcotics into South Sudan due to licensing issues, or Cox's Bazar and service delivery being impeded by the fact that the government of Bangladesh, perhaps rightfully, demands that commodities be purchased in country, and UN systems can adapt to that. And so you mentioned regulation being a challenge. What are kind of those insights, actions, challenges that we need to be considering in those situations? Thank you.
Thank you. So I know there are a couple more hands, including Katinji. I'll come back to you in a second. Sorry, we just want to make sure we have time to get to some of these. So can we maybe try to tackle Charlotte and Fatih's points from the beginning, which are really about how do we empower the women at the ground level. And we haven't really talked about community health workers, and I think Fatih, in part in her comments, was referring to community health workers, the role that they play, but being from the community. Are there any thoughts there in terms of, does the supply chain, when you think of it, include CHWs?
Yeah, and I think the other partner we haven't really talked about are the civil society organizations. From my perspective, community health workers are part of the provider, sector. I think we have to get to the last mile, and for me, the last mile is the woman in her community. Our experience, actually, to your point about health literacy, is the phone is a great tool because you can share the same information through voice. And we've had experience sharing information about quality of care through interactive voice response systems on the phone. In India, Nivi also has a voice platform. So we do think about how is it that we can make sure that we are meeting women where they are. But
you can really localize it in terms of language, dialect, right?
But the other exciting, thing is, people share phones, and so you can have a village chief, or you can have a traditional birth attendant, or you could have a community health worker bringing women in a circle and going through the platform together. And that is an opportunity not just for engagement, but for empowerment, and for education. So I think that there are ways to do this, as long as the broader framework, is still works towards that incentivization for quality medicines, and the regulatory partners are critical. You mentioned the question about the humanitarian, and conflict countries. I think that there's a role for rationalization and regionalization of some of these regulatory frameworks that would allow quicker and more efficient access, to women in need.
I want to come back to that in a second. I just want to see any other thoughts on what Charlotte and Fatih were describing in terms of the voice of women on that topic.
Well, only to say that community health workers are often forgotten in terms of supply chain planning, and it's a critical point. For example, forecasting needs. Oftentimes the requirements for community health workers will be consolidated up and then forgotten about, and so it's an important aspect. I think there's growing realization that, oh yes, you can't have it both ways. You can't pretend they're part of your health system in terms of service delivery, but then not also account for them when you're doing your planning for supplies and supply chain.
And even their paychecks are lost in the mail.
Exactly.
In many parts of the world, right?
Exactly.
Yeah.
And maybe, I'm aware that we are discussing a very broad and complex agenda, and we're scratching the surface. So we have been able to only talk about some elements. And coming back to a question, I think from Kenya on the first round of questions, and how can we create an enabling environment for women to really be agents of change and demanding better services, and I think it's also coming back to the comment made by the representatives from Ghana. I think it would be interesting to look at the HIV experience, because the HIV community in the early days, they really have approached HIV as as a right to health issue, a human rights issue, and demanded treatment when it was only available in the north, demanded quality treatment, demanding better behavior of health workers. It's not that the situation is ideal, far from, but I think the approach to look at health as a human rights, where all people are entitled. It's not it's an entitlement. It's not a blessing or exactly. And I think we'll need to, as a health community, to learn those lessons from the HIV response, because I think they have been tremendously important, and they have been very disruptive. They have upset quite a lot of people, but it has been tremendously successful.
It shows the power of advocacy.
Absolutely, and of activists.
Right, and it underlines the point if we say that health is a human right. Remember what we heard at the very beginning of the conversation from Kristen: 3 billion people don't have access to essential medicine. This is not if it's a human right, we are far from achieving that human right.
Yeah.
We had this question from Jennifer about sexualized violence, and I just wanted to see whether we've talked a bit about behavioral science and its applicability to stigma broadly. And she's curious to know, has this topic come up around sexualized violence? Is that something you've seen in any of your work so far?
So I think, specifically around the sexualized violence question, for us in the maternal health space, what we've seen is that it's often a confluence, of these critical vulnerabilities in societies that are causing women to die. So whether it's the violence and the inequality, the gender inequality in the US, it's the confluence of race and gender that is creating huge disparities in maternal health outcomes. And so what we have had to take a step back and talk to our partners about is these drivers are multifactorial. And so we need multi-sectoral, broad approaches and partnerships to dealing with them. It's not a silver bullet, it's hard work, but it's also a long-term, we need to think about this for the long term. So what I would say in answer to that question is we need to connect all of the dots, because if we don't connect the dots, we're not going to get to the SDG goals.
Sometimes the most powerful things are just the most obvious things. And it's obvious, but we've come from an industry that has long looked at people as widgets, right? And we can think of everyone in just economic terms. Well, there's a woman in a village, she doesn't have access to medicine. It must just be that she doesn't have the money. But that's not the whole story.
Yeah.
And we all know that, and we think about it for just a minute. So I think behavioral science has enormous applicability across many, many issues. Thank you for raising that one that we hadn't gotten to. So we've a bit out of time here, but I know Gitinji Gitahi's CEO of AMREF is with us. I wanted to hear your thoughts. We've used your name in vain a couple of times already.
Thank you very much, Raj, and thank you to all the panelists here. I guess you refused to pick my question earlier. You wanted me to make closing remarks?
No, just
okay, fine. I'm just kidding. Well, I think one of the things that I remember more recently is my mother lives in about 170 kilometers out of Nairobi. And, she's 84 and she prefers to live there. And we've tried to tell her, she said, no, I live here with my one cow and she's happy there. And I'm referring to what my colleague from Ghana was talking about. So recently she's asthmatic and she gets all her medication from, high-level doctor, specialist, and then she gets an attack. She goes to the local health center, not a health center here, level 4 hospital, and she gets a prescription, but because the hospital doesn't have the supplies, she gets one medicine and she has to buy the other two. When she went, what had been prescribed for her was a cough syrup. She ended up with a medicine to reduce breast milk production. Because the way it was written by the doctor and the interpretation of the unqualified pharmacy assistant ended up with her having a medicine for reducing breast milk production at 84. But because she doesn't trust the system, she looked at it and said, I've never seen this drug before, I'm not going to take it. So I want to get back to the issue of behavioral science and say that actually behavioral science can be used to build trust, but trust is what builds behavior. And I think until we build health systems that people trust, behavioral science will just be something we talk about in here. So the most important thing is how do we build health systems that people trust? Now, the 2 points. One is the issue we haven't discussed here about the role of government. Because in all these things, government is the regulator and the balancer of incentives. The private sector, which has been referred to here, has different incentives from the public sector. If I own a pharmacy, my biggest incentive is profit. It's the truth. It's, so if somebody comes, and Kemat will know that, I worked in the pharmaceutical industry many years ago, and there used to be something we call cargo. Cargo was counterfeit medication or medicines without a source. You don't know where it's coming from. It was cheaper than the branded product. Therefore, you bought it off the black market and you sold it because it had a higher margin. But what is the role of government in post-market surveillance to ensure that there is quality medications? And what is the role of government in ensuring that the systems can be trusted by the people? So that's the first thing I want to say, that we must not forget the role of government. The next issue that I want to very quickly talk about is community health workers. And I finish, right. Community health workers are the builders of community trusts. And I don't think we talk about them enough, that actually they are not just a part of the health system. They are a critical part of the health system because they're the ones who interpret the quality issue. They're the ones who talk to my mother. They're the ones who actually make sure the medication, if there's a problem, they refer back. So community health workers are in the middle of this. And that should not be forgotten. So we must remember in universal health coverage, poor quality is expensive and makes the healthcare system unaffordable. So quality, investing in quality is actually a step forward for universal health coverage.
Absolutely. In fact, you can applaud that. Please do. I quote this gentleman in my book. He has a fantastic quote in there, which is, we don't do UHC because we are rich. We do UHC because we are poor. Right? UHC is seen in many places in advanced countries as a luxury. How can we afford this? But actually, as I think we've heard in the conversation today, which we do need to wrap up now, I think we've heard that in many ways, the money is there, the markets are there, we can get to every person in the world, and it might actually be more efficient. It makes much more sense, whether we're thinking of pandemic threats or whether we're thinking about the need to make sure no mother dies needlessly in childbirth. So the opportunity is right in front of us. I wonder if there's a final comment from each of you, because we do need to wrap up. And I'll hope it's quite tweetable and brief.
I don't know. I kind of think he did it. So.
Okay, thank you, Beth. Marika?
No, I think the only thing I was thinking as was listening to the discussion, just that unequal access to health is not a low-income country issue. It's a global issue, and a lot of countries are struggling with it in different ways. Yes. Women's access to health and the respect for women's right to health is contested in all sorts of contexts. I think it's a global agenda. We are fighting millennia probably of patriarchy, and but it's a fight that we have to fight.
We must.
Yeah.
Final thought?
Women need to be at the center of our health systems, and we need to create those channels, whether they're the community health worker channels or the digital channels, to have those connections strong and actionable.
Thank you. I want to thank all of you who are here in the room, all of you who are following us online, which may well include Lawrence Evans in some airport somewhere in the world. So thank you to USP for partnering with us at Devex for the UHC at WD event. I think you see the importance of the conversation. It is a topic we at Devex are continuing to cover and are committed to. And I thank you, all of you, for the incredible conversation. Please join me in thanking the panel today. Women Deliver.